Yes, Dr. Manoj, go on.
Respected chair, seniors, and my dear friends. At the outset, let me thank Dr. Tiroumourugane and the organizers for having called me to.
Dr. Manoj, your volume is a bit low. Can you try to increase it?
Is it? How about now?
A little bit better.
It's in from my side. It's full.
Yeah. Okay. Please go ahead.
Okay. So in the next 15-20 minutes or so, we just look at the basic principles of transport of a neonate. I know we all know that neonatal transport is a one-day workshop by itself. So I'll try to give the nutshell, the bird's eye view of the whole thing. So we would just try to look at this, how to stabilize before transport, what are the modes available, the physiology of transport, the requirements and the care during transport, and the quality assurance. So the first thing when you're going to transport a baby is to actually assess how sick is the baby. And as Dr. Chandra rightly pointed out, newborns are a heterogeneous group, and the problems of one group is not going to be and manage the same way. The same problem in different groups are going to be managed differently. We have late preterms, we have early term and term babies, and then we have the moderate preterm, we have the very preterm, and the extreme preterm. Now we have one more group added, the below 26 week, the periviable babies as well. So all these groups, if you're going to transport each group, the criteria you use are going to be different in each group. Which is a well baby? Well, all of us know the baby who is breathing comfortably, heart rate above 100, vigorous cry, pink skin, good muscular tone. Of course, we know that's a well baby. And this is a baby who doesn't need to be transported. Manage with the mother, ensure warmth, and promote breastfeeding. Whereas if you are going to see some red flags, then this is a baby who may require transport if you do not have secondary or tertiary care facilities. Baby who is not breathing, who has some respiratory distress, who is hypothermic, who is cyanosed, who is convulsing, or has other problems like lethargy, abdomen distension, bleeding, yellow palms and soles, etc., etc. So when you evaluate this baby before you transport, the 5 vital parameters all of us know, these are things that has to be religiously checked every time: the temperature, the respiration, the breathing, not the respiratory rate, the respirations, how, what is the respiratory rate, what is the breathing pattern, how severe is the distress, or all the aspects related to respiration, the heart rate, the blood pressure, and if you cannot monitor at least a non-invasive blood pressure, the perfusion, capillary filling time may also do. And then of course the fifth vital parameter, the saturations of the baby. And of course on top of this we add the blood sugar as well. And if facilities are available, some blood gas, x-ray, and the new stethoscope for all of us, the ultrasound and echo also may give us some more tips actually. So once you have decided that the baby is sick, now the next task is to decide how sick is the baby. There are various ways to decide, and all of us are very familiar with most of the systems. So the simplest way that can be recommended for transport is the modified stop score, where you are going to assess STTOPS as is written. So the sensorium, the how lethargic is the baby drowsy, and is the tone good, and then the temperature, is the baby either hypothermic or having fever, and oxygenation, probably the most important thing, oxygenation and ventilation requirement of the baby. And then you're going to look at the perfusion, how well perfused the baby is, the capillary refill time, probably you would want to keep it less than 3 seconds. And of course the sugars as well is again one of the parameters that you would like to look at. Now temperature, we all know, the range that we want during during stabilization and during transport is 37.2 to 36.5. And of course, as I was hearing the previous session, the cooling during transport, even asphyxia babies, you will not cool passively, because unrestricted cooling is going to cause more problems. So you need to actually keep the temperature tight between 37.5, or rather 36.5 and 37. Now, the commonest symptom that we notice is respiratory distress, and you notice by the tachypnea, retraction, grunting, cyanosis, etc. And of course, you have various scoring system. Most of us use the Downey scoring system or the Silverman-Anderson scoring system, and based on this scale, you decide what is the intervention that you're going to do. Baby is breathing spontaneously, of course, you would be trying CPAP, even if the baby has some distress. And if baby is not breathing, you would give positive pressure ventilation, either with a bag and mask if you don't have the skill for intubation, or intubate and ventilate. If the baby does not have respiratory distress but is having poor oxygenation in the form of cyanosis, then probably this baby has normal CO2 levels. You don't need CPAP. You can just use oxygen. And oxygen, again, as a guideline, which we studied long back, head box, if you use with both side ports open, will give you something like 30%, and one port open will give you 60%, both closed will give you 90%, because we know that we don't want to use 100% oxygen unless we are compelled to use it. And we need to ensure adequate perfusion and blood pressure during stabilization and during transport as well. So this is again an area where a lot of this things need to be said. So I would just stop with saying ensure adequate perfusion and blood pressure. Any drugs during transport, previously surfactant used to be given and then babies used to be transported. That depends on the skill of the persons who transport the baby. So probably I would say that the two drugs that are essential are oxygen and prostaglandin. Oxygen has to be used like a drug. Do not use 100% oxygen. Try to have a blender during transport also. We know that oxygen is as toxic as any other drug if you overuse it. And of course, for those babies where you suspect critical congenital heart disease, you would like to start the baby on prostaglandin and then start transport with all the precautions that are required when you transport a baby with prostaglandin. Now, regarding the types of transport, there are various methods available: road and air, the rotor wing and the fixed wing. Probably we will be only talking about road transport and the methods of stabilization. Actually, if you look at all the methods, they can be basically summarized into two. One where your aim is to take the baby immediately to the center where where treatment is available. That is a scoop and run method. And the other one is stabilize and move. Probably in neonate, you will never do scoop and run. This is going to cause more problem than what you think. So probably you would always stabilize the baby and move. And so one of the instructions that you're going to give to the ambulance driver would be go as slow as possible, as steady as possible. Do not rush. That is going to create more problems, as is been proven by various evidences. The baby undergoes a lot of stress during transport, and probably the stress that baby undergoes can be broadly divided into the dynamic stress and the non-dynamic stress. So the dynamic stress is all because of movement. So of course this is more for air transport, but then even for road transport, when you are going to go fast and then brake suddenly, well, this is a time when babies land up with problem. Some of the studies are even reported complications like intraventricular hemorrhage and things like that when this happens, especially in preterm babies. So probably to avoid the dynamic stress, the velocity of transport should be kept the same, and it's probably in our scenario, it's easier to keep a same velocity when you use a slower speed, and nothing is going to be lost if you have stabilized the baby properly if you go slow. The non-dynamic stress are the factors that the baby, because of the disease process and the transient environment that the baby undergoes. And of course, here again, your crisis management skills are going to be of importance. Now, you need to check the equipments you are taking the baby with in the ambulance. So you should have a transport incubator with multi-channel vital signs monitoring. I am really amazed at the facility available. Probably Tamil Nadu can boast of being the first state in the country to have the best transport system available for neonates. So I'm sure that I've been interacting with so many. There are so many things which needs to be improved still, but still a beginning has been made with some a dedicated system being available for you. Now, if you have a transport incubator and you can monitor the vital parameters during transport, that will go a long way in improving the outcome of the baby. You need to keep the airway patent, and then you need to ventilate the baby. Make sure that if the baby is not breathing, you need to ventilate the baby. You can either use TPs if you do not have a transport ventilator, but make sure you control the pressures. You do not do bag and mask with high pressures for a preterm baby, 28, 29 weeks, and by the time you reach your center, half the damage will be done. CPAP is ideal if you have a blender to give as a support for respiration in respiratory distress, especially if the baby is breathing well. Mind you, transport management of CPAP is much more difficult than management of ventilator. And the airway equipments, of course, all of us know all those things need to be there. Suction devices, oral airways, bag and mask, laryngoscope, etc., etc. All those should be there. We need to have the infusion facility, infuse aids, infusion pumps, glucometer, etc. The source of oxygen, compressed air, because we are going to use a blender, you need to have a compressed air source. The mask, hood, heat, light sources, the adapter, electrical charger, all these things has to be taken care of. The disposables, the catheters, syringes, needles, feeding tubes, alcohol or chlorhexidine, betadine swabs, micropore tape, gloves, etc. all need to be available. Instrument tray for emergency tray for intubation and etc. All those things should be available, and the life-saving drugs. So these are probably some of the things that you need to be checked, and check that all these things are working as well. And make sure baby is stable before you start. So before you start and during your transport, ideal to keep the sugars, because now we know that blood glucose is a thing that regulates your body, even for you and me, not only for neonates. So glucose is something that needs to be kept at the in the euglycemic stage. And probably temperature is the most important thing as well as during transport, where things go wrong if you don't follow basic precautions. Airway breathing, I said, it has to be again taken care of in the as is the degree of respiratory distress. Blood pressure, perfusion has to be maintained, and whatever lab works are required before and during transport has to be done. The communication part with the parents and the emotional support during transport also you need to be making sure they are available, and of course the drugs are there. Now, if you do not have a low-cost incubator, if you do not have a incubator, then probably kangaroo mother care is a method of transporting neonates, provided the baby is stable to have this. So most of the babies, if you have the correct techniques, probably this may be one method where if mother is fit for transport. And one of the things where we find genuine defect, this is what we from various audits. I've been going through various audits and surveys, and one of the comments that is being made in most of them is the lack of effective communication. So if a communication needs to be effective, what is required is a closed loop communication, which means that X tells Y, Y tells that he has understood, and that the loop has to be closed. X has to realize that Y has understood, Y has to get back. So this closed loop communication has to be done during the stabilization between the team members, and during the transport between the team members, and then you need to be at the same time communicating with the referral center if possible on a live basis. I'll tell you a little bit about this. So this is where we go smart. There are various technologies available, and communication during transport can be revolutionized by simple innovations. One of them, I just say, for example, is the smart apps that are available, that have been developed by various institutes, where you have facility for constant communication to the control center. The control center for this communication would be the referral center, where somebody will be monitoring the transport, especially if a experienced person is not going for transport. The communication has to be verbal and digital. Digital in the sense that the person who is sitting in the referral center should be able to see the vitals. These days, with the accessibility of connectivity, it is not a big thing to make it available. So the person who is going to receive the baby is able to plan very well and give corrections on the way as well. And of course, some basic things, we need to make sure that all the equipment should have a battery backup and should be fully kept charged all the time. Enough oxygen supply should be there to last for the whole duration. The referring hospital and parents should be informed about the safe arrival and latest condition of the baby, and the inventory of equipment should be checked. Medications and essential supplies should be restocked for the next transport service. One of the most important thing is documentation, because this is where some of us go wrong, and then later on even it has medical legal implications as well. So if you are not going to use any smart system, the document that you're going to send is what is going to determine the fate of the baby. So documentation has to be perfect. If possible, if you have the time, take the antenatal history, record that, and then there are various checklists available. They are all freely downloadable from various sites, and make sure that all the points are scored. And then so that when the referral center receives the baby, all the aspects are there in the they know everything about the baby. Now, regarding quality assurance, we now know that any program is useless until you are able to make a change in the outcome. And so we need to have a quality management program. So the first step in this would be the data collection, the audit of how you are doing. So the various advanced systems like the TRIP score is available, where the transport risk index of physiologic stability, this is a Canadian scoring system. There are various things available. Even the demographic, whatever you data you do, you collect the data. If you are using a smart system, then probably those there are a lot of data that you can retrieve from that as well. And based on that, we need to have periodic training. This is a way to make sure that things are improved. And you need to develop your team. We know that ideally they should have a doctor, nurses, paramedics, respirators, etc. The key point in quality assurance is that train your team periodically. So the simulation debriefing exercise that we do routinely in NRP can be tried in transport as well, because it's going to pay rich dividends. And this is the way to go if you want to develop and if you want to transport your baby well. We know that the best transport system is the mother's womb, but that doesn't happen most of the time. So especially when there is preterm delivery and things like that, or suppose you after delivery you made a diagnosis of congenital diaphragmatic hernia or a critical congenital heart disease. These are scenarios where if we do not follow the basics, our outcomes are going to be much worse. I would just summarize. We should not go slow in ambulance, stabilize and transport, maintain the airway, oxygenate well, but there are targets, saturation targets available. Do not aim for 100% during transport, never. Always, when you are using oxygen, the saturation targets during transport and in your NICU are the same. So in general, keep it above 90, below 94, you would never go wrong. If at all you don't want to remember the perfect value. And then, of course, we need to make sure that thermal stability is there. You can use thermal mattresses or even innovative methods with thermocol and things like that, or kangaroo mother, various methods, but make sure the baby is warm and ensure that adequate tissue perfusion. Whether you want to feed the baby or not. Previously, we used to say that don't feed the baby, put the baby on IV fluids and send. But then now concepts are slightly changing. If your transport system is advanced, you can even consider giving feeds depending on what facility you have. But always you should have venous access available, and make sure that if possible maintain the blood glucose level, especially if you are dealing with an infant of diabetic mother and things like that, then probably this also will make a difference. And of course other aspects like the emotional support to parents and the effective communication will make all the difference. I'll finish here and take questions.